A session focused on acute GVHD diagnostics, leveraging biomarkers and patient treatment. We'll be discussing both biology and clinical cases this afternoon. So I'll give a few introductory remarks, and then I'll get out of the way and let Dr. Ferrara take over. As many of you know, Dr. Ferrara is one of the founders and leaders in the field, so I will try to take up as little time as possible, yet set the stage for his discussion. So most of us don't need any introduction to acute GVHD. It's one of the major causes of non-relapse mortality, or NRM, following allogeneic HCT. Primarily, the disease affects three organ systems: the skin, liver, gastrointestinal tract. And in that period of risk is really the first 2 to 3 months, really the first 100 days post-HCT. Sorry, getting a little feedback there. The incidence is quite high, as you know, 40 to 60% of the patients can be infected. And really this acute GVHD is one of the major limitations to more widespread use of allo-HCT in the field. The diagnosis of GVHD is often challenging. Typically, it relies on the presence of clinical symptoms in one or more of the organ systems that we discussed. Often confirmation by biopsy is the gold standard. But of course, there are a number of shortcomings to this approach, not the least of which is that, as you might well know, the symptoms are nonspecific and can often be confused with other etiologies, other common etiologies, many of which are infectious in nature. Second, the biopsies are often inconclusive. We get a chance to talk to a lot of healthcare providers in the field, and it's not an uncommon story to hear about biopsies just not being that useful. Other pathology services have better service, I think, than some, but we certainly do understand that biopsies are challenging, and of course, we know they're invasive as well. And then finally, waiting for either the onset of clinical signs or the biopsy results does present a significant delay, and that really eliminates the possibility of preemptive treatment. So for a number of years, there's been efforts to discover biomarkers that can lead to improved diagnostics. I'm just showing you an example here from a paper published by Pachesny et al. About 10 years ago, really taking an expression, a gene expression, a protein expression approach, where they looked at GVHD positive. Sorry, I thought I had a marker there. Anyway, GVHD positive on the right and GVHD negative on the left samples, and just looked at fold differences in the expression of various protein biomarkers. You can see 4 that I've highlighted here. This group selected for further study: IL-2 receptor alpha, interleukin 8, TNF receptor 1, and HGF. And these researchers looked at the diagnostic performance of these biomarkers, both individually and then as a composite. You can see individually the area under the curve was greater than 0.5, but still not excellent. Some of the biomarkers, such as TNF-R1 and IL-2 receptor alpha, did have a much better area under the curve. And then when they looked at a composite, and this composite was derived by logistic regression, they actually came up with some pretty good diagnostic values. You can see in the training set and in the validation set, the AUC was about 0.9 or 0.86. Several years ago, this effort shifted to more of a proteomics approach, and I'll show you a couple of examples. This first is for Reg3 alpha. In this example, they started out with about 562 different proteins that they identified and quantified. They narrowed that down to 74 that had a greater than 2-fold increased expression in GI GVHD. And then they narrowed that down further to 5 proteins that were expressed in the gut. And then one of these, there was a readily available antibody ELISA, Reg3 alpha. So this was selected for further study. And as you can see in the right, patients with diarrhea and GVHD, biopsy-confirmed GVHD, had an 8 to 10-fold increase in Reg3 alpha plasma levels relative to either patients with diarrhea and no GVHD, patients with nausea, vomiting only, whether they had GVHD or not, or even those with no symptoms or skin GVHD. So this work really pointed towards the value of Reg3 alpha, specifically in assessing gut GVHD in clinical patients. The second biomarker that was studied more recently is ST2. And you can see in this study published in 2013, the ST2 levels for either grade 1 and 2 or grade 3 and 4, 1 and 2 in the orange line and 3 and 4 in the red line, GVHD, were much higher than those with low ST2 and lower grades GVHD. That was for the non-relapse mortality, the mortality without relapse. If you included or looked at mortality with relapse, of course, that effect went away, pointing to some significant specificity towards the GVHD process rather than just the relapse itself. So overall, while this work has been encouraging, there have been limitations to the past efforts that we think, based on the work Dr. Ferrara will present in a few minutes, we've largely overcome with future work, with current work. Those limitations include standardization of methods was often lacking. Many of the studies were research-based, and clinical studies that followed were difficult to compare and replicate simply due to the variability in the methods that were used. Additionally, the selection of optimal biomarker sets continued to evolve. So while there was a significant shift recently to proteomics approach, even before that, there was just a common evolution that made it difficult to pin down a single set of biomarkers. Most importantly, though, large-scale multi-site validations were often not performed, and so much of the work Dr. Ferrara has concentrated on in the last several years has been centered on these large-scale multi-site validations, as well as the establishment of clinical cutoffs. So that was something that we haven't seen in the past, so we now have with much of the current work. And then finally, many of these biomarkers were not available in CAP, CLIA, the clinical reference labs that many physicians depend upon for their results with the HCT patients. So with that, I will turn it over to Dr. Ferrara, and he will take you through biomarkers for acute GVHD, the clinical work, and the biology as well.
So thanks everybody for coming. And there's some seats here, like there's one right next to Steve, and there's another one over here, so please sit down. So I'm going to spend a little time in the beginning orienting you to the biology of the biomarkers. And then the majority of the talk is going to really be about how we use them clinically. And if you are ordering this from Viracor, some examples of what you're going to see and how that relates to a patient that I'm going to take through a transplant at various stages of GVHD. Okay, so by the end of the hour, you should be able to understand how the biomarker algorithm represents a liquid biopsy of the small intestine, and you should be able to interpret the algorithm results for patients before GVHD symptoms, at the onset of GVHD symptoms, at the time of them, and then after GVHD treatment. So if you haven't spent a lot of time thinking about the crypt in the small intestine, you're going to do so for the next 5 minutes or so. So we now know a lot about the biology of how the crypt, which contains the stem cells, come on down, guys, come on, that's great. You're so nice to come in. There are a couple of seats over here, and particularly on this side. So the reason that we're focusing on the GI tract is that for those of you who've taken care of patients, it's the GI tract, GVHD in the GI tract, that kills our patients. That's where we've got the most resistant disease. If you went to the plenary session this morning, you heard a lot about new approaches to GVHD, and that when they are successful, they are often inhibiting a damage in the GI tract, either the trafficking of cells to the GI tract, or actually preserving some of the key cells that are important for regenerating crypts. So we now know that the intestinal stem cell resides at the base of the crypt. It is a, oops, oh, I see. How bad can I get? I just turned it off, right? So that's forward, and there it is, okay. So the intestinal stem cell sits here near the base of the crypt. It always sits next to a Paneth cell. Work done by Hans Clevers in Holland about 10 years ago showed that you can start with a single intestinal stem cell and you can grow an entire villus, essentially a mini gut, in culture. And you absolutely need this intestinal stem cell. The cell that sits next to it is called a Paneth cell. A Paneth cell is not a stem cell, but they always reside next to the stem cells. And if you put two of these cells next to each other in culture, you can get 10 times the number of organoids that grow. And we now know that there are very important signals that go back and forth between the stem cell and the Paneth cell. And the Paneth cell essentially keeps the stem cell in a stem cell state. The Paneth cells are often called the bodyguards of the crypt or the bodyguards of the intestinal stem cell, not only because they provide these growth signals like Wnt3, but they also, the Paneth cells are very granular. And inside those granules are a lot of antimicrobial peptides, like defensins. One of the really interesting molecules in a Paneth cell, though, is called Reg3. And it's Reg3 alpha in human and Reg3 gamma in mouse. I'm going to show you both mouse and human data, but if you could just remember that it's Reg3 alpha in human. It's a C-type lectin. It's specific for gram-positive cocci. And as Steve just showed you, we found it as a biomarker for gastrointestinal graft-versus-host disease when we weren't particularly looking for it. The early studies that we did were looking for immunologic-type molecules, cytokines or cytokine receptors. When we were doing this proteomics approach, it was what we call a non-biased approach. We had no hypothesis going into the discovery. We were just looking at serum from patients with GVHD and without GVHD, and what were the proteins that were more abundant in the serum for patients that had GVHD. And Reg3 came out as one that was very important for GI GVHD. The second one that came out, and which Steve also told you about, is the suppression of tumorigenicity, or ST2. It is the soluble receptor that is shed from lymphocytes, particularly T lymphocytes, after its ligand, IL-33, binds to the T cell. Now, IL-33 is made in Paneth cells and in other epithelial cells, and it usually stays cytoplasmic. But if it is released, it's called an alarmin. It's an alarm signal for other cells, particularly for immune cells, and it is then activates particularly T cell responses. And so we also found this in this non-biased approach, and work by Sophie Pachesny and others have shown actually that all of the ST2, or the 98% of the ST2 that is found in the bloodstream during graft-versus-host disease comes from the GI tract. So I'm going to spend the next 10 minutes or so really talking about Reg3 alpha, because that's the biology that we've just really been able to understand more completely in the last year. But, and then we will get to the clinical studies. So we're going to go back to mouse for a minute. This is a model of matched unrelated donor transplantation in mice. And in the black circles are mice with graft-versus-host disease, and in the white circles are syngeneic transplants where there's no GVHD. And what you can see is that the serum level of Reg3 increases dramatically in the first 2 weeks in mice that have graft-versus-host disease. When we looked in the intestine to confirm that this was true, we found a big surprise. This is immunohistochemistry staining for Reg3 in brown. And what you can see is that in the mice without graft-versus-host disease, there's a lot of brown staining. In fact, this protein is being produced all over the GI tract, whereas in the mice with graft-versus-host disease, there's hardly any. This was not what we had predicted. In fact, it was the exact opposite of what we had predicted, and it's a problem because we couldn't find the Reg3 being produced anywhere else in the mouse. We looked in the pancreas, we looked in the thymus, we looked in the lung. There was nothing that showed us where it was coming from. So we had to do some more experiments. And the first experiment we did was to see, well, maybe the mouse model is wrong. I mean, I didn't like to think that because I've been working in mouse models for 30 years, but maybe it was just something that was different about the mice. So here's the quantitation of what I just showed you. Here's no GVHD and then with GVHD, and you can see that, that in the serum the levels go up, but that they go down tenfold in the intestine where you would expect it to be made. And what we found was that in humans, it's exactly the same pattern. So we had biopsies from patients, and we also had serum from those same patients at the time that the biopsy was taken. And we had, and these were all transplant patients, and some of them had graft-versus-host disease, and some of them didn't have graft-versus-host disease. And what you can see is that in the patients with GVHD in black, the serum reg3 was about 10 times higher than it was in the patients without GVHD. But in fact, when you do quantitative immunohistochemistry, and my pathology colleagues hated me for this experiment because it's very difficult. You have to do all of the slides simultaneously. You have to read them in a coded fashion. They had to get a scoring system of what was 0, 1, 2, and 3. And they said, we really don't want to do this. And I said, no, you really have to do this. And eventually we found that it was the same pattern in humans that it was in mice. So the mouse model was accurate. Oops. And what we found was that this paradox, what we call the, high in the serum and low in the intestine where it's being made, it actually increased. The paradox got worse as the GVHD became more severe. So here are mice. This is, again, the next couple of slides is all mice. What I'm showing is that if you add in increased numbers of T cells and the GVHD gets worse, the serum, the clinical score, here it's no GVHD, a little bit, severe GVHD. The serum goes up, look at this, between the mild GVHD, so this is the clinical score, but the serum reg3 goes up about 100-fold. So it's a very sensitive indicator of GI GVHD. And then, but what you can also see is that the amount actually goes down. We're looking at mRNA expression. So that suggested that it was the lack of reg3 in the intestine that was bad, and that reg3 was actually somehow regulating or controlling GVHD. So we did the same sort of experiments with the same kind of GVHD induction in mice that were completely identical, except one recipient mouse was a wild type and could make reg3, and the other mouse was a knockout and they couldn't make it. And what we found was that, so these are mice without graft-versus-host disease, and the number of Paneth cells, which for this, we're taking that as a measure of destruction, of target destruction. That was normal. It goes down in the wild type, as you would expect. But if the mouse couldn't make reg3, it lost even more Paneth cells. So it's the GVHD was worse. And then when we looked at the infiltration for the purposes of this, these were CD8 positive donor T cells that made gamma interferon. That is one standard measure of effector cell function in these models. And what we could see is that they were up in the mice that got graft-versus-host disease, and they were up even more if the recipient could not make reg3. And finally, the survival, this is the survival for the wild-type animals that could make reg3, but if they couldn't make reg3, the survival was worse. So absence of reg3 was bad. Now, I'm not going to show you all of the data. These are, in fact, published last year in the Journal of Clinical Investigation. But we also know that the cytokine that is responsible for the production, the induction of reg3, is something called IL-22. And it's made by a rare kind of innate lymphoid cell in the base of the crypt. I'm not showing you the data, but the animals with graft-versus-host disease actually had very little IL-22, and they lost it before they lost the reg3. So Alan Hanash had shown this, and we did a similar experiment where if you give the IL-22 back, can you rescue the animals? And the answer is yes. You can rescue them here in two different models. So if you give the IL-22 right here, you can go from 50% survival to 90% survival, and that's in two separate models. And what happens is when you give the IL-22, in the tissue, the reg3 production goes up, but you can see that in the serum, the reg3 protein that's being released goes down. So in effect, this is what gave us the initial clues that reg3 in the serum is a measure of damage to the intestinal stem cells. You're breaking apart, particularly the crypt, the reg3 that's been stored in the Panna cell, and in the mucus, it's a large molecule, it's heavy, it gets stored in that mucus, and then it gets dumped into the circulation when the crypt is destroyed. So here's now, these are wild type animals that recipients that are being rescued with IL-22, and if the recipient can't make reg3, the GVHD is worse, and IL-22 can't rescue them. And it's the same in a second model. So reg3 is critical to the ability of the intestinal stem cells to repair the crypt. And I'm just going to show you that, again, when we looked now, and we've got special mice, we can look at these intestinal stem cells and count them. And when you've got GVHD right here, when you give IL-22, you rescue the stem cells, but if you can't make reg3, IL-22 can't increase that stem cell number. So it's absolutely critical that you have reg3 to regenerate the crypt. And then what we found was that we knew, as I told you before, we knew that it's an antimicrobial peptide, but it turns out that it has a completely separate function of preventing the death of those stem cells. It actually doesn't cause their proliferation, but it stops their apoptosis. So this is IL-22 in the wild type that stops the apoptosis as measured by this annexin 5. But if you don't have reg3, you can't prevent that apoptosis. So that was the big key. And then when we looked at this, there's a lot of very good work that's been done about the microbiome in graft-versus-host disease, and it's certainly dysregulated in GVHD. But when we look at sterile cultures in vitro, where there's no microbiome, what we found, so these are two separate cell lines, when we stress them and we cause apoptosis, as in here, and then we add reg3 into the culture, we reduce the apoptosis, and then here we can show that in a dose dependent fashion, as you add more reg3, those cells become more and more viable. So it is an anti-apoptotic protein as well as an antimicrobial peptide. And this just shows now that in vivo, in these mice with graft-versus-host disease, the number of intestinal stem cells is directly related to the amount of reg3 that's being produced. Okay, so to kind of summarize this part, during graft-versus-host disease, the two biomarkers, ST2 and reg3, serve as a kind of liquid biopsy of the crypt, because reg3 increases in the serum as it decreases in the GI epithelium, and as the Panna cells are destroyed, they spill their intracellular contents into the systemic circulation. It acts as a survival signal rather than a proliferative signal, and it also shows that there might actually be new ways of stimulating the innate immune system that is inherent in the epithelium, rather than just trying to suppress the T cells, which is what we do at the moment, either with calcineurin inhibitors or methotrexate or steroids. There might be a new way of actually attempting to get to graft-versus-host disease. So we're very excited about both the biology as well as now its clinical application. I'm going to show you now some data that we've generated over the last 10 years that have been collected from our consortium that looks at acute graft-versus-host disease. So this is the Mount Sinai Acute GVHD International Consortium. It's got this cute acronym called MAGIC. It's about 24 centers in the US and Europe. When we started to get these biomarker results, some of my colleagues from around the country said, well, could you measure biomarkers in our patients? And the answer, after Dr. Levine, who's my colleague and co-director of MAGIC, and I thought about it, said, yes, we'll measure the biomarkers for you, and we'll measure them for free, but there is a price. The price is that you have to put your clinical data into our database. And all of the data managers that put the data into the database have to take a test and pass it so that they're putting in accurate data. And they have to pass this test with 90% or better. Actually, I helped design the test, but when I took it the first time I failed because I wasn't following the rules straight. So that's how hard the test is. But we now know that we've got very accurate clinical data, particularly at the onset of graft-versus-host disease, or even before, and then we're going to compare how the biomarkers do related to the clinical phenotype. So in our consortium, these are data that we published almost 2 years ago now. We know that there's about a 13% non-relapse mortality in the first 6 months after allogeneic transplant, and this was from about 20 different centers. And when we looked at the biomarkers and we used this algorithm that combined the concentrations of both ST2 and REG3, what we found is that we could split those patients into a low-risk group, which was about 80% of the patients, and a high-risk group, which was about 20% of the patients. And the high-risk group had about an almost 30% non-relapse mortality compared to 10% in the low-risk group. And 85% of that non-relapse mortality was driven by GI GVHD that wasn't responding to treatment. As Steve mentioned, this algorithm does not at all correlate with relapse. So it really measures destruction in the GI tract as opposed to the strength of the graft-versus-host reaction. So I'm not actually showing you the relapse data, but as you can see, the overall survival remains significantly different in these two groups. So this was data that was a blood sample taken on day 7 after transplant, before anybody had any symptoms of graft-versus-host disease. And so what that's telling us is that the biomarkers that are being released into the bloodstream are a more sensitive indicator of the GI damage than the actual clinical symptoms themselves. So this was day 7. And it's true whether we looked at a number of different variables. This happens to be the related donors. So this algorithm works whether you have a related donor or whether you have an unrelated donor. You get the same sort of separation of the curves. It also works whether you've got an HLA mismatch or whether there's conditioning intensity. What you can see here is that the separation is pretty good, but in the related donors, only 13% wind up being high risk, whereas in the unrelated donors, 23% wind up being high risk. So that's the proportions change, but the actual separations of the curve do not change very much. As you would expect, in those same patients, if you're low risk, the eventual incidence of severe GVHD, so that's grade 3 or 4, this is actually GI stage 3 or 4, it's only 8% in the low risk, and it's twice that in the high risk, it's 17%. And the GVHD mortality in the low risk group is 34% compared to 59% in the high risk group, also highly significant. So that's all from a single blood sample that's taken 7 days after transplant. So now we're going to start the cases. So we've got a 33-year-old woman. She's got FLT3 AML in second remission. She gets an unrelated donor transplant with flu-Bufor conditioning, TAC methotrexate, GVHD prophylaxis. Her early post-transplant course is uneventful until about day 12 when she's febrile to 102.8 degrees 3 times in a day. There's no rash, there's no diarrhea, and her bilirubin is 1.6. So you're on the ward, you wonder whether this is engraftment syndrome, you've heard that engraftment syndrome might be bad, you decide to send off these biomarkers. And what you're going to get is this, and we'll show you. So the ST2, 85,000, reg3 is low at 8, but the p-hat is the predicted probability of non-relapse mortality. And that's 0.175, and that's high risk. So this is what when Viracor sends you this is what you will actually see. And I want to point out a couple of things. The red and the yellow are actually just black, but I have highlighted them because they are the key elements of this report. So up here it says aGVHD pre-symptomatic algorithm. So when you send the sample, it's going to ask you, are there GVHD symptoms or not? And if there aren't any, because it's before treatment, this is the pre-symptomatic algorithm. You see, so here's the test. Reg 3, it's 8. That's the lower limit of detection. So it's not there. There's no flag. Now, the reference range, Viracor did this from normals. So if you just looked at people in this room, I assume none of you have had a transplant recently, the reference range would be 42. So there's no flag here. But the ST2 is at 85,000. It is high because the reference range is less than 16,828. Now, I'm going to tell you, these aren't actually the numbers you want to look at, and they can be a little confusing. The number that's meaningful is right here, the acute GVHD algorithm at 0.175. That's what you take those concentrations and you put this into the equation, and that's the number that you get out. And then right here, they say risk of severe acute GVHD and non-relapse mortality, no GVHD symptoms, so that correlates with the acute GVHD pre-symptomatic algorithm. Less than or equal to 0.16 is low risk, and greater than 0.16 is high risk. So that's the point, that's what you need to know. This is high risk, and that means that this woman is now on this curve. She's got about a 30% chance of non-relapse mortality. Now, the best treatment, I believe the best treatment for patients with graft-versus-host disease is a well-designed clinical trial. So at the moment, there is a trial in MAGIC centers of preemptive immunosuppression for this kind of patient. It's with alpha-1 antitrypsin that we're giving twice a week for 4 weeks. So this kind of patient, and we've already had 14 patients who have been accrued to this trial. I can't tell you the results yet, but the DSMB has said that the trial should continue, and it's because this person is at high risk. Now, let's go back to that patient. Exactly the same patient. She's been fine. She's febrile ×3 on day plus 12. She doesn't have any symptoms. You're going to send off this, and now the results come back. Exactly the same ST2, but the actually lower ST2, also low reg 3, and now she's low risk. So I'm showing you this because, and this is where this report can be confusing. We've already talked about this is low. The ST2 here, 26,369, it actually comes out as higher than the normal reference range, but when you put it into the algorithm, she still comes out as low risk. And if you actually put these into the algorithm, it comes out at about a 0.078. So normal people have a non-relapse mortality risk by this algorithm of 0.078. So anything below that is normal. So even though this is flagged as high, this is the number that you need to look at. And so this person would be on the low curve, and that would be, if you did anything, you wouldn't preemptively treat for graft-versus-host disease, and you might have a brief symptomatic intervention for those fevers that she's having on day 12. Okay, let me just pause there and ask whether that's clear, because we're going to take this patient now through a next stage of her journey, but if you've got questions right here, okay. That was before symptoms. At the onset of symptoms, this is how we had initially looked at these biomarkers. If what we initially did almost 8 years ago was to use 3 biomarkers, TNFR1, REG3, and ST2. And what we published 4 years ago in Lancet Hematology was an algorithm using those 3 biomarkers that could also divide patients at the onset of graft-versus-host disease into 3 separate groups. You've just seen how the algorithm gives you a single probability. And then we use thresholds to say, are you low risk, intermediate risk, or high risk? So this was, and because we were doing this work in Ann Arbor, we called them Ann Arbor grades. My children wanted me to call these Ferrara grades, but I said, no, these are going to be Ann Arbor grades. So from 1 to 14 was low risk, 2, and then actually the way we did this, we did low risk and high risk, and then we just let the intermediate risk fall in between. And so Ann Arbor 3 was 0.291 to 0.999. And you can see what the and the endpoint for the algorithm, when we developed the algorithm, it was always non-relapse mortality, because we had very clear data on that. At 3 years ago even, we weren't so sure about things like, as a firm endpoint, things like steroid-resistant GVHD, or even a grade 4 GI GVHD. So we used non-relapse mortality. And you can see the 3 differences here, which again, relapse was the same, and here's the overall survival. We were and are using standard kits to measure these. We did not develop the antibodies. So these are R&D kits that we buy and pre-coat and then do a lot of quality control on. So they changed the capture antibody for ST2, and it changed the algorithm in a nonlinear way. So we had to rederive it 3 years ago. And when we rederived it, it turned out we didn't need the concentration of TNFR1 in the algorithm anymore. We could do it with just the 2 biomarkers of ST2 and REG3. So that was also in this JCI Insight paper that I showed you. And now, here are from the MAGIC Consortium. I'm going to show you the data for patients whose clinical grade at onset was grade 2, and these are 252 patients. So when we use this new algorithm, here's what we find. Again, here are the 3 non-relapse mortality curves with highly significant differences between each of the grades. So this is now using the 2 biomarker algorithm. Here's the steroid resistant. So the Ann Arbor ones, as you would expect, only 20% become resistant to steroids, whereas the Ann Arbor 3s up here, it's 50%. And perhaps most interesting, when we rederived the algorithm, what we now found was that the proportion of low-risk patients it's actually a supermajority. It's 61% of the patients are low risk, about a quarter of them are intermediate risk, and 15% are high risk. So this is all patients who are presenting with grade 2. So let's go back to our patient. She had engraftment, and by the way, for the purposes of this, she was actually low risk, because remember, 80% of the patients are low risk when you do that pre-symptomatic test. So she was given 1 dose of steroids, her fevers went away, she was discharged on day 17, she comes back a week later, it's fine, but she comes back she calls and says, I've got a rash, and you say, come to clinic right away. So she comes in on day 29. She has a rash that's 80% of her body surface. She's had 2 episodes of diarrhea in the past day. That actually, we did this. We've kind of quantified, because patients never come in, at least my patients never come in, and say, I've had 650 cc's of diarrhea in the last day. You know, it's like, well, how many times you go to the bathroom? I was there all day. Well, was it 1? Was it 2? So it turns out that the average volume of a diarrheal episode in an adult is about 200 cc's. And that's what we use now for all of our database about, you know, if you can't tell how much it was, but they're giving you the number of the episodes, that's what we use, because that's the average. So she's still at a stage 0 for GI disease, and her bilirubin is 1.7. So this is an overall grade 2, right? She's got stage 3 skin, 0 gut, 0 liver. So you send off the biomarkers. Now she's got about 50,000 ST2, and her reg is really low. It's still at 8. So her p-hat here is 0.119. So that's an Ann Arbor 1. This is what it looks like. Please notice that at 50,000, it's still flagged as high because that's higher than normal, but here it's 0.119. Now you'll notice this says up here, aGVHD symptomatic onset algorithm, which here now you have 3 lines, less than or equal to 0.14, 0.14 to 0.29, or 0.29. So this is the number you need to look at, and this tells you how to interpret it. Okay, so that patient is on this curve. She's got only 20% chance of having steroid-resistant graft-versus-host disease. Now, I believe that we are over-treating most of our patients with grade 2 GVHD, but we don't know until the biomarkers came along. We didn't know which ones were going to be low risk or high risk. So we actually have a phase 2 trial of non-immunosuppressive, well, non-steroid treatment for these patients. And we have a phase 2 clinical trial of itacitinib monotherapy for patients with GVHD that is low risk by biomarkers at onset. Okay, same patient, same clinical presentation now on day 29 with an 80% rash. You send it out, and for illustrative purposes, it's now the same ST2, but now her reg 3 is 653. This is now a probability, a p-hat of 0.317 or an AA3. So you can see this is the same. Now 653, that gets a flag here, and 0.317. But this is still the number that you need to look at. You can actually be high on both of these and still be low risk. And still be at a p-hat of like 0.10, which for all of these thresholds would be low risk. So that's the number that you absolutely need to look at. And now she's on high risk. And for this patient, so remember, she doesn't have any diarrhea yet, right, so to speak. It's only 400 cc's. So, but it's telling you that there is crypt disease that has not yet become clinically evident. So this kind of patient needs more aggressive immunosuppression, and there's a phase 2 clinical trial of anti-alpha-4, which is natalizumab, which stops T cells trafficking to the GI tract. Okay. It turns out that you can follow biomarkers after treatment as well. So we've now looked at, we published this last year, we have looked at biomarkers after 1 week of steroid treatment for GVHD. And what we found, and this is also published, it was in Blood, actually you can still get CME credits for taking the quiz on this paper, if anybody's interested. But if you look at the receiver operating characteristic curve, so most of us don't live with ROC curves, but this is the sensitivity on the y-axis. This is 1 minus the specificity on the x-axis. So a diagonal line is a lousy test, right? It's 1 true positive for 1 false positive. A terrific test is an L bracket, where you would have 100% sensitivity and 100% specificity. Early clinical response. So have you responded after 1 week of steroids? That gives you an AUC of 0.68. If you look at Minnesota risk, which is good at onset, it also turns out to be somewhat useful after 1 week. That's got an AUC of 0.65. The biomarkers alone, though, with this algorithm, have an AUC of 0.82. And if you add response, clinical response to biomarkers, it only goes to 0.83. So if you have only one bit of data that you want to know about a patient after treating them for a week with steroids, it's actually the biomarkers and what the probability is, because the response, the clinical response, is not as sensitive or as specific, which you can see here, because it's more sensitive and specific than the clinical responses alone. So it's got a sensitivity of 74%, a specificity of 83%. So in the validation set, these were 68 patients who were steroid resistant. So they had about a 35% non-relapse mortality and overall about a 60% survival. That's everybody who's not responders. You ask what the biomarkers do, and you get this. It turns out that over 2/3 of these patients are actually low risk. They're not non-responders. They're slow responders, and you haven't seen the response yet. So if you take all of these non-responders and at that point you do the biomarker algorithm, what you're going to see is about 30% are very high risk, but the rest are low risk. So back to our patient. We're going to call her high risk. She's got high reg 3. Her probability at day 29 was 0.317. So she comes back, and she never does get diarrhea. So you sort of watch her overnight. She looks better. She doesn't feel bad. She's eating a little bit. So you send her home. She comes back to clinic, and on day 37, she's still got a rash. She's skin she's skin stage 3. She's had one loose stool. That's GI 0. And her bilirubin is 1.8. That's still liver 0. So she is acute graft-versus-host disease, grade 2. No response. This is a patient who would be eligible, for example, for a steroid-resistant trial. But she doesn't have gut disease, and you want to know whether you've made a difference in terms of your treatment. So you send off the biomarkers. And now she's got still high ST2, moderately high ST2, but her reg 3 has come down dramatically, and now her p-hat is 0.229. That's low risk after treatment because the cutoff is 0.291 right there. So greater than or equal to 0.291 is high risk. So that's greater than 0.291. She's 0.22, but notice it's still high and high here. So you've got to look, this is post-treatment algorithm, and then you have to look here and then for the interpretation here. So she is actually responding. And if she were our patient who is on natalizumab plus steroids, she's on this curve, and she's got an 80% overall survival rate. So if it were my patient, I would continue her on the natalizumab and steroids and not add anything else. Okay. So reg 3 and ST2 are released into the bloodstream from damaged intestinal epithelium, and so the algorithm using their concentrations represents a liquid biopsy. It provides the single predicted probability, or p-hat, of non-relapse mortality for each patient with thresholds for the risk. Before the onset of GVHD, the algorithm characterizes patients as either high or low. At initiation of GVHD treatment, it gives you 3 separate risks of Ann Arbor's 1, 2, and 3. And after GVHD treatment, it categorizes patients as either high or low. Thanks to everybody who did this work, particularly John Levine, who is my co-director of MAGIC. And now I'm happy to answer any questions you might have, and if people have to leave, I'll stay afterwards, if that's okay. I think we have a microphone so that people can hear what the questions are. And thank you for your attention.